Good afternoon, everyone. I am Dr. Ranjan Gupta. I am Associate Professor in Department of Rheumatology, and I welcome all the audience on behalf of our department for the combined clinical rounds for today. Rheumatology is a complex subject where we have diseases which can present in myriad of manifestations. And today we bring before you a case where disease has presented in a complex form. We are doing this presentation in association with Department of Pathology, and I first of all invite Dr. Pallavi Vij to start the presentation of the case. Thank you.
Good afternoon, everybody. So the Department of Rheumatology is presenting the combined clinical rounds for today. I'm Dr. Pallavi Vij, Senior Resident in the Department of Rheumatology. And the case that we are presenting today is of a 37-year-old male Hindu graduate farmer from Uttarakhand, non-smoker, non-alcoholic, with no known comorbidities or addictions. The history started 4 years back when he started experiencing complaints of polyarthritis, which was symmetrical onset inflammatory involving small and large joints of the upper limbs and the lower limbs, associated with early morning stiffness. No other CTD or vasculitic related features at that point of time. The patient was then evaluated outside, and his RF anti-CCP were positive with raised ESR and CRP. And on the basis of his clinical picture and investigations, he was treated as rheumatoid arthritis and received DMARDs in the form of methotrexate and sulfasalazine. However, he stayed to be non-compliant with his therapy and had frequent exacerbations of his joint symptoms over the next 4 years. When, in October 2021, he presented to a local hospital with complaints of epistaxis. It was moderate in amount, episodic with 3 to 4 episodes per day, with no prior history of any trauma. This was followed by development of swelling in both the lower limbs, which progressed to development of anasarca over a period of 1 month, and was also associated with complaints of fatigue on exertion and frothiness of the urine. There was no history of any reduced urine output, shortness of breath, chest pain, palpitations, cough, hematemesis, jaundice, fever, any oral ulcer, skin rash, or any other CTD related features, or any constitutional symptoms such as loss of weight or loss of appetite at that point of time. His past and family history was not significant. As well, there was no history of any recent intake of any drug or any alternative therapy. So, on the basis of these complaints, he was evaluated and managed outside conservatively. He received multiple courses of low-dose oral corticosteroids. We'll be going on to the review of investigation a little while later. Although he did not complain of any significant relief in his symptoms, and his anasarca continued to progress and worsen. Thus, finally, he presented to us in February 2022 this year with complaints of persisting and progressively worsening anasarca with mild symptoms of polyarthritis, which was arthritis, which was involving just one knee joint, that is left knee joint, associated with pain and swelling, and and a complaint of uncontrolled hypertension was requiring more than 3 antihypertensives in a day. When he presented to us on examination, we could notice pallor, bilateral pedal edema was present in the lower limbs, and BP was 160 by 110 despite being on antihypertensives. Rest, journal, and systemic examination was normal. Musculoskeletal examination revealed one swollen and tender joint count of the left knee joint associated tenderness and swelling of the left knee joint. His hand showed some flexion deformities in bilateral fifth PIP joint, which was suggestive of sequelae of previous history of his inflammatory arthritis. Thus, to summarize his history and examination at this point of time, we have this patient of inflammatory polyarthritis, which had been treated as a seropositive rheumatoid arthritis from outside, who now complains with epistaxis, came to us with complaints of epistaxis, anasarca, and in the examination revealed some anemia and new onset uncontrolled hypertension. We reviewed his investigations, which was done over the past 3 months, which revealed significantly low hemoglobin levels with a baseline of 5.6 gram per deciliter, which despite receiving PRBC transfusions multiple times in the last 3 months, did not raise beyond 7.7. His renal parameters were deranged with a rise in the urea and creatinine of a baseline of 58 urea and a creat of 4.8, which progressively worsened over the next 2 months to a level of creatinine level of 5.7. Apart from that, there was also history, the investigations also revealed hypoalbuminemia. A peripheral smear was suggestive of microcytic hyperchromic picture. Further investigation showed presence of iron deficiency, explaining his anemia. His urine examination showed presence of proteinuria and some active sediments in the forms of RBC and WBC, and 2 to 3 fine granular casts. A 24-hour urine protein was done, which revealed nephrotic range proteinuria of the range of 5.4 grams over 24 hours. Rest of his radiological investigations were normal except ultrasound KUB, which revealed a grade 2 renal medical disease with approximately normal kidney sizes. Thus, at this point of time, our possibilities were presence of this case being SLE, which was either misinterpreted as inflammatory polyarthritis, which is now developing renal complications of lupus nephritis. The other possibility remained ANCA-associated vasculitis, which can again present with complaints of inflammatory polyarthritis in the beginning, and now the patient is developing complaints of glomerulonephritis. While other possibilities were, although very rare, but RA-related renal diseases have been seen in the past, or it could be an unrelated renal disease which is not related with his autoimmune disease. So further, we advise some immunological investigations to be done at AIIMS. He underwent these tests, which shows ANA and ANCA were negative. RF anti-CCP were positive, which was the case as during the onset of this disease, when again his RF and anti-CCP were positive. ENA and dsDNA were negative. His complement levels and cryoglobin and cryofibrin were also negative. There was no evidence of any hepatitis in the form of HBsAg and anti-HCV being negative. Further, we wanted to rule out some malignant etiology, so we did a serum and protein electrophoresis. No MBAN1 seen in the electrophoresis. His routine investigations revealed persistence of anemia, still deranged renal parameters with raised urea and creatinine, and persistence of hypoalbuminemia with a 24-hour urine protein still in the nephrotic range, although it had improved a little bit from the baseline. It could have been because he received some multiple courses of oral corticosteroids, although low doses. So to summarize at this point of time, we have a 37-year-old male with a history of inflammatory polyarthritis, now developing a nephrotic range proteinuria with a new onset uncontrolled hypertension and anemia, and investigations revealing RF anti-CCP positivity, but ANCA and ANA remain to be negative. So after these immunological investigations, we would like to review our differential diagnosis, and we don't want to change any of our differential diagnosis still, because we know SLE can present, lupus nephritis can present in some patients with ANA negativity. So also ANCA is also seen to be present, so ANCA is also seen to be negative in nearly 15% patients of ANCA associated vasculitis. So our differential at this point again stayed the same. Further, we reviewed his renal biopsy, which was done outside from the pathologist in AIIMS to further elaborate the kind of his renal involvement. We would like to invite the Department of Pathology, Dr. Adarsh sir, to elaborate over the findings.
Good evening, everyone. I'm Dr. Varun. I'm training in renal pathology at the Department of Pathology. I'll be discussing the pathology findings. We received the outside review biopsy with block, and the biopsy was in 2 cores, comprising of 11 glomeruli, out of which 5 were globally sclerosed. There was present one fibrocellular crescent was present, and the tubulointerstitial chronicity, which is the interstitial fibrosis and tubular atrophy, consisted of about 40% of the biopsied parenchyma. This is the periodic acid shift stain, which is demonstrating 2 glomeruli here, in which we can see that the capillary loops are visibly thick. So for comparison, if you see the tubular basement membrane here, it's very thin, and these loops are pretty thick and stiff. There's also a fibrocellular crescent, which we can see over here in this glomerulus. The adjacent glomerulus is completely and globally sclerosed. We can also see the tubulointerstitial compartment, which has got inflammation as well as tubular injury with a lot of chronicity that we can see. This is the arterial profile, and it appears to be unremarkable. There are no associated changes in this artery. This is the hematoxylin and eosin stain of the 10x power, in which we can appreciate the lobular accentuation pattern, which is seen in this glomerulus. We can see that each lobule is accentuated, and you can see individual groups of the capillary walls along with their mesangium separated out. along with which we can appreciate there is mesangial hypercellularity along with matrix proliferation. To appreciate better, we go to a higher power, that is the 20x, and here we can see the lobular accentuation quite well. This is the mesangium showing mesangial hypercellularity. More than 3 nuclei are visible in the mesangial stalks, as well as endocapillary hypercellularity. This is a capillary wall in which you have proliferation happening inside. So this is endocapillary hypercellularity. In the adjacent glomerulus, we can see the thickening of the loop, which was demonstrated earlier on PAS as well. Further on Jones silver methenamine 20x, we can see the characteristic reduplication. So you have one line here and one line here. This is a characteristic tram track appearance, which is seen in a membranoproliferative glomerulonephritis. And we performed the paraffin immunofluorescence on the available thing, and we have positivity for IgA, which was present in mesangial as well as capillary wall location. A similar presence was noted for IgG and IgM. C3 was less in comparison of about 1 plus. C1q was even lesser, traced to 1 plus, and kappa and lambda were about 2 to 3 plus respectively. So based on the above findings, we gave a diagnosis of an immune complex mediated membranoproliferative glomerulonephritis in view of the membrane reduplication and the proliferative activity in the mesangial as well as the endocapillary location, with moderate tubulointerstitial chronicity of about 40%.
I would like to thank Tessa from Department of Pathology for such elaborate discussion. And on the basis of these findings of membranoproliferative glomerulonephritis, which was revealed in the renal biopsy, which was done outside for this patient, we ruled out the possibility of SLE and ANCA-associated vasculitis, as the renal picture was not suggestive of either lupus nephritis or any autoimmune glomerulonephritis, which could be ANCA-associated. Thus, remained the other possibilities that we had kept in the beginning, which is RA-related renal disease. So, we could comfortably at this point of time come to a final diagnosis of a seropositive rheumatoid arthritis with membranoproliferative glomerulonephritis as a rare renal involvement in this patient. The patient was started on oral corticosteroids at higher doses at 1 mg per kg per day. Further, he received other treatments in the form of antihypertensives and HCQ. And as the patient had responded earlier to low-dose corticosteroids with slight improvement in his nephrotic range proteinuria, we further plan to immunosuppress the patient with mycophenolate mofetil. On receiving the treatment for nearly 1 month, we repeated his routine investigations, which revealed an improvement in this hemoglobin level. His renal parameters also improved from the baseline and 1 month back also, with a current serum creatinine of 2.9. His albumin levels improved, and his 24-hour urine protein also showed serial improvement, with a presence of 1.9 gram at present. Thus, we could comfortably say that the patient is favorably responding to therapy. Both anasaka and renal functions are improving well. And currently, the patient is on oral corticosteroids at 20 mg per day, and we plan to slowly taper the dose. And he started on mycophenolate mofetil, which he's receiving at 2 grams per day presently. Further, he's receiving antihypertensives and HCQs with a high protein diet. To further elaborate on the discussion and provide a review of literature, we have Dr. Sehaj from our department.
Good afternoon, everyone. I thank Dr. Pallavi and Dr. Varun for an elaborative description of the case and the biopsy findings. So we'll move forward with the review of literature. So we'll move forward with the review of literature. So why is it important to, why are we stressing on the renal involvement? So one thing we need to know is that it heralds a poor prognosis and warrants aggressive immunosuppression. So we need to diagnose it early so that we can manage it well. So the renal manifestations are not uncommon in rheumatoid arthritis. It varies from 8.8 to 15%. And they are often associated with the cardiovascular events and the increased mortality. Previously, renal involvement in RA, it was believed to be mainly because of the medication toxicity, as we used to use old conventional synthetic DMARDs like gold, penicillamine, which are no longer used. and NSAIDs also. So the secondary amyloidosis was also quite common as because of the delayed and ineffective treatment. So because of the lesser nephrotoxic and aggressive treatment, it has altered the spectrum of the renal lesions. And one more thing we need to be careful about is that it is very difficult to accurately evaluate the renal lesions in rheumatoid arthritis just based on the clinical features, proteinuria and active urinary sediment. Renal biopsy is very much necessary to accurately diagnose, treat and prognosticate the patients. So what all clinical presentations can what all renal clinical manifestations patient can come up with, the most common being asymptomatic urinary abnormalities, which just stresses the fact that we need to periodically assess the renal functions in RA patients. Need not ignore that. Another, secondly, the patient can come up with the nephritic syndrome or nephrotic syndrome, or they can present with rapidly progressive glomerulonephritis as well, and can also present with features of cryoglobulonemic vasculitis. Even though autoimmune diseases are a well-known cause of MPGN, there is a paucity of data on the frequency, clinical presentation, and renal outcome of RA patients. So the authors reviewed the cases of MPGN which were performed between the years 2002 to 2012 at Mayo Clinic. So they took all the biopsy proven cases, 308 biopsy proven cases of MPGN, and out of that only 17 were associated with the concomitant autoimmune diseases, which underlines the fact that MPGN is a rare manifestation of autoimmune diseases. And out of these 17, 2 refused research authorization, 1 had associated monoclonal gammopathy diagnosed. So only 12 patients had complete renal biopsy evaluation. So these were included in the trial. So of these 12 patients, 5 had underlying RA, 3 had primary Sjogren's, 2 had undifferentiated connective tissue disease, 1 had primary sclerosing cholangitis, and 1 had Graves. So I'll be focusing more upon these 5 RA patients. So out of these 5 RA patients, majority were middle-aged to elderly patients, predominantly female, and majority had elevated creatinine and elevated proteinuria, 24-hour proteinuria at the time of renal biopsy. Two of them requiring dialysis at the time of renal biopsy, and majority were having longer duration of disease, ranging from 5.5 to 32 years. Serologically, of these 5 RA patients, all except 1 was ANA positive, all were ENA negative. Majority of them were seropositive, had RF titers were high, and 2 of them were having associated type 2 cryoglobulinemia as well. Majority were having low complement levels, either C3 or C4. So on renal biopsy, the percentage of globally sclerosed glomeruli ranged from 0 to 25%. Percentage of interstitial fibrosis and tubular atrophy, it varied from 5 to 50%. On immunofluorescence microscopy, IgM was the predominant immunoglobulin which was deposited along with complement deposition, and the predominant sites of deposition of immune deposition was subendothelial and mesangial, as is known to be there in MPGN. So the mean duration of follow-up was 18 months. All the patients were treated with steroids alone or in combination with either MMF or cyclophosphamide or azathioprine. Rituximab was given in the patients with associated cryoglobulinemia. So the patient number 5 was diagnosed with CML at the time of renal biopsy, so he was excluded from the trial, received treatment for that. So rest of the 4 RA patients, they were followed up, and most of them improved in the form that none of them required dialysis at the follow-up, and they had a significant decline in the serum creatinine and significant decline in the proteinuria as well. So, what all type of renal lesions can be there in RA? Like, is it only glomerulonephritis? So, RA can affect all the components of the kidney, like including glomerulus, tubules, interstitium, and blood vessels. So this was the Indian study which was done. The data is from July 2010-2015, and they studied patients of Indian origin. So the most common histological pattern of glomerulonephritis, which could be seen, was mesangial proliferative glomerulopathy, followed by membranous nephropathy, and they could also see tubules and interstitium involvement in RA, and they could also see the blood vessels involved. So usually what we always think of is that one, membranous nephropathy and tubulointerstitial involvement can only be secondarily to the medication toxicity. No, it can be because of the diarrhea disease itself. And talking about this Indian study, there were total of 90 patients were included of RA with the renal involvement. Out of these, 42 patients were having stable renal function, so they were biopsied. Rest of the 48 patients who had CKD at the time of entry, they were not biopsied. So the mean duration of these patients was of 10 years. Rheumatoid factor positivity was seen in 80% of patients. So the most common presentation, again, it was asymptomatic urinary abnormalities. These were the followed by nephrotic syndrome and nephritic syndrome. And the patients, like 53% of patients in this study, we could see they had CKD at the time of entry in the study. So we just highlights the fact that we need to periodically assess the patients even despite them being asymptomatic. So of these 42 patients who were biopsied and those who had glomerular diseases, they were followed up. The mesangial proliferative being the most common histological pattern of injury, followed by membranous. So in this slide, we can see that the around 20% of patients with focal EPGN, which can be considered as contemporary to MPGN, went into a complete remission in comparison to 30% and 50% of the mesangial proliferative and membranous nephropathy patients. So just shows that MPGN does not have a really good outcome. If we talk about the CKD patients, who are the rest of the 48 patients, if we see the baseline characteristics of those patients who had CKD, majority of them were middle-aged to elderly, predominantly being female, had longer duration of RA, and elevated inflammatory markers and elevated creatinine at the time of entry. So similar findings were replicated in another study which was done on patients of Chinese ethnicity. In the study, total for 56 patients of RA with renal involvement were studied, and they had again majority of them were clinically asymptomatic. If we talk about the clinical manifestations, so majority asymptomatic. Again, I would say that we need to periodically assess the renal function of RA patients. Need not ignore that, and followed by, if we see the most common symptom the patient presented with, it was pedal edema, followed by either oliguria and hypertension. So looking in the lab abnormalities, all of them had proteinuria, out of which 46.4% had subnephrotic range and 32% had nephrotic range proteinuria. 35 patients had microscopic hematuria. So this study also again split the patients into either, actually this was a prospective observational study. So when they followed up these 56 patients, so they saw that certain patients had a stable renal function, certain patients had renal function decline. So what all risk factors were associated with renal function decline? So one, majority of patients who had renal function decline, they were females, they had longer duration of disease, they were middle-aged to elderly, they have elevated serum creatinine at the time of presentation, and on renal biopsy, they had more percentage of globally sclerosed glomeruli and moderate to severe IFTA. So these are the poor prognostic factors which indicate that probably these patients are more likely to land up into CKD. And following up the patients who had this glomerulonephritis, they tried to look into if there was any relationship between the histopathological types and RA disease duration or deformities or inflammatory markers. So there was no significant relationship which was observed between these histopathological types or RA disease duration, deformities or elevated inflammatory markers. So I would briefly talk about the clinical presentation, the pathophysiology and the causes, and how to approach and treat a patient of MPGN. So membranoproliferative glomerulonephritis, which is formerly known as mesangiocapillary glomerulonephritis or lobular glomerulonephritis, it accounts for approximately 7 to 10% of glomerulonephritis and is the third or fourth leading cause of end-stage renal disease in primary glomerulonephritis. It typically includes mesangial hypercellularity, endocapillary proliferation and capillary wall remodeling with mesangial interposition and duplication of GBM. So basically MPGN, it is a histological pattern of injury. It is a lesion, right? It's a histologic lesion. It is not a disease entity per se. So what we see in the morphological images on the renal biopsy, so the pattern of injury, if you have these typical findings like mesangial hypercellularity, endocapillary proliferation or duplication, we call it membranoproliferative glomerulonephritis. And what are the clinical manifestations? So the clinical manifestations vary from benign to slowly progressive to rapidly progressive. So it depends like at what time point patient is coming, at what time renal biopsy has been done. So if it is done early and the patient has proliferative lesion, more of proliferative lesion, the patient would have nephritic picture. Okay, if the patient is coming late and there is more of sclerosis, more of reparative changes on the renal biopsy, the patient would have proteinuria. And if usually patients come with nephritic, nephrotic, both phenotype, nephritic, nephrotic phenotype, they'll come up with the ensuing proteinuria and hematuria. So usually we get nephritic, nephrotic phenotype, and the most common being obviously asymptomatic. As we all know that previously MPGN was classified into 3 types. Previously it used to be on the basis of electron microscopy findings, and the newer classification is based on the immunofluorescence picture. So previously it used to be on the basis of electron microscopy. If you used to have subendothelial deposits containing immunoglobulins and or complement levels, it used to be labeled as type 1, which was the most common finding, which was the most common type. 5 to 10% used to have type 3, in which there was subendothelial, intramembranous and subepithelial deposits of C3 either alone or in combination with immunoglobulins. And if you have only intramembranous deposits containing C3 only, it was used to be called as type 2. So basically, the MPGN, it is either MPGN, this glomerular pattern of injury is either immunoglobulin, immune complex mediated or complement mediated. Now, nowadays we classify it as like that only, like either it is immune complex mediated or complement mediated on the basis of immunofluorescence microscopy. Like on immunofluorescence microscopy, if you get positive immunoglobulins with or without complements, we call it immunoglobulin mediated. And when you have this immunoglobulin mediated, then you always try to look for the cause. Like what can be the reason of immune complex mediated? Either there is a deposition of there is definitely a persistent antigenemia or even episodic antigenemia for which there is a circulating antigen antibody complexes are there which gets deposited in the glomeruli and are causing this pattern. So either we look for any secondary infection, any like chronic hep C, there can be viral, bacterial, protozoal infections. In viral, generally there is like hepatitis C or hepatitis B is rarely. Bacterial, you can have endocarditis or even meningococcal meningitis. In protozoa, there are many infections. So mostly either there is a deposition of circulating antibody antigen complexes and they're getting deposited in the in the glomeruli leading to this pattern, or there can be any autoimmune disease, underlying autoimmune disease like SLE, Sjogren's, RA or mixed connective tissue disease. Or there is monoclonal gammopathy because of which those immune complexes are circulating and they are getting deposited over there. So the newer classification has just helped in the fact that you can have, if you have immunoglobulin mediated, you look for these causes, and if you have complement mediated, then you look for the mutation or antibodies to the alternative pathway complement components. So generally the complement mediated glomerulonephritis is mainly because of the dysregulation of alternative pathway of complement. Dysregulation of alternative pathway of complement means that either it is getting activated unnecessarily because of the mutation in the complement factors or mutations in the complement regulatory proteins, or there are antibodies to complement factors or complement regulatory proteins, which is leading to the unnecessary activation of the complement components, and they are getting deposited over there, leading to the damage of the glomeruli. And if you're finding there is an MPGN pattern, but you are not able to see any immunoglobulin or complement deposition on the immunofluorescence microscopy, so then we look out for the rest of the causes like antiphospholipid antibody syndrome, healing HUS or TMA, sickle cell anemia, polycythemia, and there are certain drug also associated with it. Yeah, sure. And the approach to the treatment is that we need to the treatment approach to treatment is that we need to focus on the underlying disease. So if you are able to pinpoint what is the underlying disease, be it infection, immunocomplex mediated autoimmune disease or monoclonal gammopathy, treat that, and it is best managed the supportive care and careful use of immunosuppression. So if you are not able to find out any cause of the underlying MPGN, then we call it as idiopathic immune complex mediated glomerulonephritis, which generally is treated with supportive care and RAS blockade. And high dose glucocorticoids immunosuppressive are used in the cases if you have rapidly progressive glomerulonephritis or you have abnormal EGFR with active urinary sediment and with any level of proteinuria. What are poor prognostic factors? Lastly, nephrotic syndrome, elevated serum creatinine if you have hypertension at the time of presentation, or if you have increased number of recents on the renal biopsy, or if you have moderate to severe IFTA, that shows poor prognosis of the renal disease. Thank you.
Thank you, Dr. Sahaj, for concluding the presentation, and now the house is open to take any questions.